Good morning, you guys. We're going to talk a little bit about some of our GU pediatric problems. So we have the 3 kidney problems. We'll talk a little bit about pathophysiology and about, there's only 2 objectives that go into this piece. And so, and those are listed on the first page or the first slide. So we'll talk a little bit about clinical manifestations and nursing interventions. Well, good morning, Miss Amy. How are you? I don't hear you. You're probably still connecting. All righty. So we'll do clinical manifestations and nursing interventions of each of the problems. And then we'll talk a little bit about the acute kidney failure or the acute kidney issues that we have related to those. So in your first one with your acute glomerulonephritis, remember that they've been sick. They've had a strep infection or they've had a staph infection, and now they've been on antibiotics or whatever, but now for a week to 2 to 3 to 4 later, and all of a sudden the body's response, antibody response to this illness has really caused problems with the kidneys. And all of these antibodies, it's kind of in hyperdrive, and all of these antibodies are getting caught up in the renal tubules and in the glomerulus. And so it's making it so filtration can't happen, and it damages that basement membrane in such a way that red blood cells leak through. So think about with your clinical manifestations, if you have kidneys that are not filtering and they're dumping red blood cells, what are some things you might see in this patient? Well, if they aren't getting rid of all their fluid, then they're going to have some edema. And since this is happening in the glomerulus, which is right prior to the renal tubules, where you have your salt and water reabsorption, it causes problems with the salt and water balance and makes them hold on to salt and water. And that is going to drive their blood pressure sky high. When they have a really high blood pressure, what are some of your interventions? If they're holding on to fluids and they're edematous and they have a high blood pressure, then we need to get the edema down. So we need to not be giving them fluids. We need to be limiting those. We need to be limiting their salt intake, or we're going to perpetuate that edema. We're also going to give them antihypertensives about 90% of the time. So think about your symptomology, your clinical manifestations. So they've been sick and they're on antibiotics. If they are still taking those antibiotics, we would have them continue. If they're done, we don't give them another course. Sorry. We don't give them another course of antibiotics because that doesn't help. Then then you look to, they might have a fever. They'll be lethargic. They're not feeling very good. And you get to your intervention. So what are you going to do about it? You're going to monitor their vital signs, particularly their blood pressure. You need to be right on this. When you're looking at a clinical manifestation of, if you have kidney injury, are you going to have very good urine output? Are you going to have, they're leaking some proteins, so it will be frothy. So what little bit they have is going to look like Coca-Cola or like iced tea, but it'll be kind of frothy like a beer on top because of the protein. Then they also, so when you go to your interventions, you're going to watch your labs. You're going to see what that BUN and creatinine are doing. If you have kidney injury, that's going to drive those levels up. Then you want to make sure that when you're watching your vital signs, that you're seeing if your antihypertensives are being effective. You want to see if the edema is going down. So you're going to give them some diuretics. Diuretics will help because it's a salt and water issue. So when their edema is from something else, like in the next one, in nephrotic syndrome, then diuretics aren't as helpful. When you look at nephrotic syndrome, so we'll kind of shift gears, then you're going to be looking at what are your, this is not someone who has been sick. The other one is an immune response. This is something that is directly a kidney problem, something that has caused a kidney issue, whether it's like chemotherapy drugs, autoimmune drugs, damage to the vagus nerve, whatever the case may be, there's damage to these kidneys. Now, this damage is such that protein leaks through, massive amounts of protein, and then you don't have it in your vasculature. So if you don't have protein in your vasculature, you don't have good enough oncotic pressure to hold your fluid in there. So it will leak into the tissues, and it leaks a lot into the tissues. So these guys are going to be, it's more insidious, so it's slower onset, where in acute glomerulonephritis, think acute. They're acutely ill, it comes on quick. With nephrotic syndrome, this whole syndrome kind of comes on slow to where sometimes it's pretty advanced before they finally catch it. They will have more edema, and to the point of anasarca, where they have the generalized edema, and they have ascites. So sometimes they are so swollen that their little bellies are swollen. So you really need to make sure that you're keeping an eye on that and measuring their abdominal distension. They also, so they have the edema. They have, they don't have a fever or anything because this isn't an immune response. This isn't something that they're sick with. It's just a kidney issue. Then they're going to be losing their immune globulins and their clotting factors, or clotting inhibitors, sorry. So if they're losing clotting inhibitors, they're going to be more prone to clots. So what are you going to do about it? So you want to be able to give them anticoagulants. If their clotting factors, or if their PTINR or PTT are indicating that you need to do that, especially if they have a D-dimer that's high. D-dimer is indicative of a possible clot, so they can look at that too. But mostly they're going to be worried about the generalized edema and the kidney failure, so impending kidney failure. So right now they're damaged and they're leaking so much protein that we've got to rein that in. And we've got to give them corticosteroids that will help diurese that fluid. So why aren't diuretics as helpful? Because this isn't a salt and water issue. It's a protein issue. It's an oncotic pressure issue. And the corticosteroids, it's kind of a long pathophysiology that you don't necessarily need to know. But the corticosteroids work in such a way that it helps to diurese that fluid. It helps to bring some of the fluid back into the vasculature so that they can get rid of it. The only time they use diuretics with this one is if they have so much fluid in their lungs that they have kind of a pleural effusion, or they have crackles, rails, that they are really having a lot of difficulty breathing, needing some oxygen. Then they will give them some diuretics to see if they can pull some fluid out of their lungs. But for the most part, frontline is corticosteroids. They can sometimes give hypertensives or antihypertensives. It's kind of a 60-40 thing where about 40% of the time they need some antihypertensives. But for the most part, it is not the sky-high blood pressure that you will see with acute glomerulonephritis. We need to protect them and teach them good hand washing. Make sure that they are staying away from people that are sick, because these guys will get better enough to go home. And then they're treated a little bit on an outpatient basis. This is the one where it can reoccur and have a remission, and reoccur and have a remission. And so they really need to have good education on how to stay healthy because they're losing those immune globulins and they won't be able to fight off infections as well. Then we're going to talk about hemolytic uremic syndrome. So this one's a little different than the other two because they're edematous, but they're not holding on to as much fluid as the other two because mostly they're losing it. One of the hallmark signs is hemorrhagic colitis or bloody diarrhea. With this bloody diarrhea, they are going to sometimes be hypotensive. If they're losing enough blood and enough volume, then they can have some hypovolemia, and that will cause hypotension for them. However, if they're only having a little bit of bloody diarrhea and they're still hanging on to a fair amount of fluid, then they might be a little edematous. They rarely use antihypertensives in this one. They can, for sure. There's always a few cases where they need to, but it is much more rare. Then when you look at that HUS triad, so you've got the three issues that are kind of indicative of this. So you have the hemorrhagic colitis or the hemolytic anemia, so the breakdown of the red blood cells that's causing them to excrete it through the GI tract. And you have thrombocytopenia. So if you have thrombocytopenia, what does that look like? What does that patient have that you would go, oh, their platelets might be low? So they might have some bruising, some petechiae. So make sure that you're looking for that when you're getting a good history and doing a good assessment. And you look at the last of the triad piece, and that's kidney failure, acute kidney failure. So in this one, they need dialysis much more often. The first two, sometimes might need a couple of treatments to kind of get them over the middle point or over the hump. This one will often need several treatments, and sometimes it can last quite a bit longer. But the other thing that is so different with this one is the neurological component. These guys can have a lot of neurological issues. 100% of the time, no. 75% of the time, absolutely. And then anywhere kind of in there, but it's definitely upper range. I would say I've probably taken care of 10 or 15 kids, maybe a little more, I don't know, with HUS, and they've all had a neurological component. Some that are just a little confused and have a decreased level of consciousness that starts to resolve over a couple of weeks. One that had a TBI that was lasting, it didn't go away. I've seen them be in a coma. I haven't seen a stroke, but that's one thing that I want you to remember with these guys is they do have that neurological component. And so be very aware of safety issues with them because they might just inadvertently get up and get out of bed or pull out an IV and they most often need a dialysis catheter that's in their subclavian vein right there on their chest. And so they are at risk of maybe pulling that out if they're very confused. Those bleed like crazy. So definitely need to have somebody watching them if that's a confused patient. Make sure you're doing good neuro checks. And in all of your diets, make sure you're limiting salt and water. And in the first one, acute glomerulonephritis, and in HUS, you're going to limit your protein too. Protein is a little bit harder for kidneys to break down or to filter out. Sorry, not to break down. To filter out, it's a larger molecule. And so you don't want to tax the kidneys a lot. You want to give them a break. But in nephrotic syndrome, we are losing protein at a high rate of speed. And so we've got to have some in our diet to be able to get that oncotic pressure back and be able to have some protein in their system. So they will have moderate protein in their diet. I hope that helps you guys kind of with the pathophysiology a little bit. If you remember why it's happening, and it's going to help drive those clinical manifestations. and nursing interventions for you. Amy, since you're my only one with me, do you have any questions that somebody else might have also?
No, I don't have any.
Okay. Sometimes when one or two of you guys are on, I put you on the spot because every once in a while, if you have a question, I'm betting somebody else does.
No, I'm good.
Okay, perfect. All right. Well, I think that's it. I hope you guys have a good rest of your week and a good weekend. And I will talk to you tomorrow, Amy.
Okay.
But I'll
Thanks.
talk to the rest of you guys next week. Have a good weekend.
You are currently